Hey everyone, and welcome to another edition of the Understanding Sports and Exercise Medicine Research Show, the show that brings you the latest research straight from the horse's mouth. I'm your host, Tim Travail from Torrens University in Melbourne, and I'm here to support clinicians and early career researchers in the journey through the complex world of health-related research. We're fortunate to be joined today by up-and-coming researcher Brooke Patterson. ACL injuries continue to plague team sports, and I suspect may well play a feature in the increased injury rates that some are predicting as we start to come out of COVID-related restrictions. Brooke has produced some excellent ACL work as part of our PhD that we dive right into today. If you enjoy the episode, and if you get a moment to share or rate it on iTunes, I'd really appreciate it. So without further ado, let's get into it. I'm pleased to be joined by ACL specialist, clinician and researcher Brooke Patterson. Brooke's an experienced physiotherapist, having worked in both sports and public sectors, and is currently undergoing her PhD at La Trobe Sport and Exercise Medicine Research Centre, where she's investigating the impact of ACL reconstruction on the lives of young adults. Brooke's a high-level former WAFL athlete, that's Aussie rules for our international listeners, and has undergone an ACL reconstruction herself. Brooke works to combine her football, physiotherapy, research and leadership experience to encourage young athletes to stay fit and healthy. Other career highlights include being physiotherapist for the Red Hot Chili Peppers, and that's the kind of superstar clinicians we want on this show. So Brooke, welcome to the podcast.
Thanks, Tim. You've really done your research there.
I have. I try my best. All right. So just before we get into the paper, can you just tell the listeners a little bit more about your current areas of either clinical and or research focus?
Yeah, sure. So I worked for about 4 or 5 years when I graduated from uni as a physiotherapist, kind of public, private health, was going down that sports physio track with a few teams, and then Adam Colviner, who's now my current PhD supervisor, managed to twist my arm to come and do a PhD, and over the last couple of years I haven't been working clinically, just with focusing on the PhD and footy commitments and the like.
Okay, excellent. And just to introduce the paper under the discussion today, so quite an array of sort of people involved in this from different institutions by the look of it. We can perhaps hear a bit more about that in a second. But the paper's titled "Poor Functional Performance 1 Year After ACL Reconstruction Increases the Risk of Early Osteoarthritis Progression." And that's in the British Journal of Sports Medicine just this year, 2020. So this is very recently published, is that right?
Yes, and we're actually looking to make it open access at the moment as well. So keep an eye out for that.
Okay. So just a bit of background then to this paper. What sparked your interest, and what perhaps was the pre-work that you or others have done that really led you up to this paper?
I guess firstly to disclose, I was a participant in this study, in this longitudinal cohort, and Adam Colviner, who's an author there, you can see, he conducted the 1 year assessments, and then I, as part of my PhD, have conducted the 5 year follow-up assessment. So obviously from my own personal experience of going through the injury and recovering the physical component and getting that confidence back, kind of stemmed my interest in this area and to do a PhD, but also I guess as a clinician, seeing a lot of those injuries in the clinic as well and how hard they were to rehab with the patient. And then I guess in terms of a research perspective, why we wanted to answer this question in particular is I guess these functional performance tests are often used to clear patients for return to sport, and they've been shown to reduce re-injuries in the future. But no one's really looked at the implications on these tests on osteoarthritis and structural changes.
And how long ago was it that you when were you a participant in this study? When did you when you playing footy when you did your ACL?
No, basketball actually. I was up very high in the air and got a force on the back of my leg, so it wasn't a real typical mechanism.
Yeah.
But that was it's come up to 10 years. So all these patients in this cohort are coming up to 10 years this year.
All right, so perhaps we'll start off with touching around the sort of methodology. So that covers a bit of the introduction and the background as to why we've got to this study. But can you just give us an overview of the study design? You've mentioned the participants, where they came from, but just if we can get into the study design, and then we'll go from there.
So obviously they all had an ACL reconstruction. They all had a hamstring graft, and they were by the two authors in the paper, Hayden Morris and Tim Whitehead. So they all kind of, I guess, we didn't monitor what rehab they underwent, but the surgeons obviously have their own rehab protocol, so we're confident that they're getting the same messages. We don't know for sure exactly what they did, so that's obviously a limitation. But we then assessed their functional performance using a series of hop tests and a one-leg rise test at 1 year after their surgery. And then we really wanted to then look at the associations between their performance at 1 year and future changes in osteoarthritis features on MRI, and also change in patient-reported symptoms, function and quality of life in the preceding 4 years, so using the 5-year follow-up.
Okay, and in terms of the actual hamstring graft as a methodology, is that just the sort of surgeon's preference, or is that something that was in your inclusion criteria specifically to only look at those patients, or how did that?
No, it was really surgeon preference. Yeah, so it was a convenience sample.
Yeah.
And then some of the work about him, I guess, shows that there's no difference in arthritis or clinical outcomes between those graft types as well. So I guess we're, in terms of the generalisability of this study, only being hamstring grafts, we are confident that these concepts are transferable to other graft types as well.
Okay, and surgeons, are they primarily only doing these types of grafts these days, or was there a reason why you didn't include different types of hamstring grafts in this study?
No, it was really predominantly what they were doing at the time.
Yeah.
I know some of surgeons from that group are now starting to do a few more of the quads tendons. Yeah.
Yeah. Okay. All right. And then just going towards the bottom of page 2, for those who have got a copy of the paper, we've got an outline of the numbers here and a flow chart of the recruitment into the study, and then the completions right through to the patient-reported outcome measures and the MRI. So, were you pretty happy with the continuity through from the start to the finish? There, is that in line with other similar research you've seen in this type of area?
Yeah, they're a difficult group, I guess, to track long term because they're young adults. A lot of them, moving overseas, moving into state, so that did limit our ability to do some of the face-to-face testing. But around that 20% dropout is pretty consistent with other studies.
Yeah. And what happened with this incorrect? I can see that one person. What happened here? What's the backstory? So we've got one dropout because we had an incorrect limb scanned.
Yeah, that was unfortunate. And then obviously I couldn't participate in the patient-reported outcomes or the functional testing because of bias either. So we lost there as well. Okay.
And that was just a bit of an odd one that happened at the scanning clinic, was it?
Yeah.
Okay.
Maybe they wanted to get a scan on that knee for some reason and told the radiographer can you just do this one?
Why not? Okay. All right, so let's keep going through onto the next page here. Is there anything from page 3 that you think is worth touching on here? Maybe we'll split into the differences, the specifics of the OA features that you were looking for.
Yeah, sure.
About the outcomes from there.
Yeah. Maybe if we start off with the functional performance outcomes. So the tests that we did were the single hop test for distance, the triple crossover hop for distance, the side hop, which is take 40 centimetres apart and that you see how many times you can hop sideways over that in 30 seconds, whereas the first two are kind of just max distance that they can hop. And then the last one is the one leg rise, which yeah, it obviously isn't involving hopping. It's squatting down on one leg to the knee at 90 degrees, and it's a maximum test. So we get them to do as many as they can. If they get to 50, great job. We stop them there. So it's more of an endurance test, and it's also, I guess, a bit of strength, because that just actually squat quite low on one leg as well. So I guess we chose those 4 tests just because they do assess multiple aspects of lower limb function, and in multiple directions as well. So a lot of previous work have just focused on, say, like a single hop or a triple hop in a straight line, whereas adding in the crossover hop, you get a little bit of multi-directional and kind of repeated power generation, absorption. The side hop, you get that really lateral movement. They need quite a lot of calf power, and they need some level of endurance, cardiovascular fitness to do that for 30 seconds. So, yeah, I guess we thought it was a rigorous battery, and incorporated all those things, and clinically feasible as well. So a lot of studies will also look at like isokinetic muscle testing of quads and hamstrings, but obviously you need specialised, expensive equipment to do that. So the reason why we went with those functional tests is, yeah. And then I guess moving on to, so that was our independent variable, and our 2 other dependent variables or outcome variables were the changes in OA features on MRI. So to touch on that a little bit, I guess the key features we looked at were cartilage, bone marrow lesions, and meniscal lesions in both the tibiofemoral and patellofemoral compartment. My supervisor, Kay, loves the patellofemoral compartment, and a lot of previous research has kind of neglected joint. So that's a big focus of our research. And I guess why we're looking at MRI is that it's obviously a lot more sensitive than X-ray to pick up early changes in the joint. And I guess it's not to say that we want clinicians to use this as an outcome. It's a tool for us to, I guess, identify individuals that may be on like an accelerated pathway towards established joint disease on radiographs. So there is some literature in the knee OA world to show that people who are at risk of knee OA, so heavier older patients, people that have MRI lesions, they do have an increased risk of going on to have incident radiographic OA and symptoms. So that's why we use MRI OA, because we can detect it early, and that's obviously when our interventions might be more effective to kind of slow or prevent that progression as well.
Okay, and yeah, I very much like the way that you've already referred to the applicability of the testing, just in easy clinical practice that we can obviously do with those other areas.
And then, yeah, obviously the patient-reported outcomes we use were pretty common, again, in the ACL knee literature, the KOOS and the IKDC, and we looked at the change. So what was their score at 1 year, what was their score at 5 years, and what was the change in that period. Again, that's something that hasn't been looked at a lot, which we thought was important to do. I guess if you think there's going to be a lot of variability in terms of where people are at 1 year on their KOOS scores, and everyone's a little bit different. So kind of, I guess, taking into account that baseline measure of their symptoms was important as well.
Yeah. Just looking at the order you were doing the actual testing, we've always talked about left leg first in the practice trials. Was there a reason why there was left leg first as opposed to injured or uninjured leg first? Or was that just pretty not really of much interest or necessary to consider?
Just trying to think. Oh, it was because we blinded so they put a thing over their leg to cover up their scar, so the assessor didn't know what was their reconstructed leg, so we just always went left, right. I mean, inevitably patients will kind of groan and do all sorts of things to give it away, but yeah, that was just a strategy to reduce that potential bias. Yeah,
that makes a lot of sense. I didn't realize that there was a single blinding there. So that Makes
I
sense.
guess the other thing I wanted to point out with the MRI as well, because it's a lot of reviewers come back a lot of the time with comments on these papers. Well, everyone has lesions on MRI, but the concept of, again, having the 2 time points, I guess, combats that a little bit. So our definition of worsening OA features included people who either had a new lesion, say so one that wasn't present at 1 year and then something that popped up at 5 years, or a progressive lesion, so something that was present at 1 year but it increased in size or severity, so like say the depth of the cartilage lesion at 5 years. So having those 2 time points, and the advantage of a longitudinal cohort study like this is that regardless of whatever they had at 1 year, because a lot of people might have had pre-existing lesions, they actually had to show some degenerative change in that time period.
Okay, and that's I suppose there would be an argument that there might be some changes. So it's over a 4-year period, right, between the first and the second MRIs, that we might see some progressive changes, but we wouldn't see too much in this age category that you're looking at. You wouldn't get too much. You wouldn't expect to see too much change in that.
Yeah, that's a really good point, and I'd encourage people to read one of my other papers, the first paper from my PhD, where we purely just describe the worsening in these OA features. So we go into a little bit of detail around the worsening rate, what you're saying, per annum compared to healthy young adults without an ACL injury. And you're exactly right. The rate of change in these ACL reconstructed individuals is much more accelerated than uninjured peers. So it's actually up around the rate or higher than older individuals with established OA. So it's kind of, I guess, this post-traumatic OA, we call it this accelerated progression.
That's a really interesting finding, obviously, to support what you're working on here. And you probably caught me out for not reading or remembering your early work. I apologise for that.
No, it's all right. Cheap plugs.
And just the other point, I suppose, that might be pulled out is just the reliability of the reading of the MRIs. And I know that you've put in some validation work around that. Is that something you can talk to?
Yeah, so one of the authors, Ali Gramazi, I hope I've pronounced his name correctly. I haven't met him, but emailed. He has been involved from the start in grading the MRIs. So they go in in Melbourne, have the MRI, and we send those scans to him to grade. And he's actually done a lot of work with David Hunter and actually published a lot of work in the reliability and establishment of the MOCS grading scale. So we've kind of got the best in the business in terms of our radiologist.
That's excellent, because I think a lot of the information we see, or the comments around that is sort of in general practice radiology, isn't it, where we probably get more variability than what you've got here. So
yeah.
All right. Anything else you wanted to pull out of the methods? Otherwise, we can have a look at the stats and just talk about your general principles of what you're looking at in terms of the analysis.
No, I was going to add something on the stats, but you can ask away.
No. Well, okay, we can get into the stats then. So I just want to look at, so you're getting some good information there on a range of different areas. So can you talk us through what type of statistical analysis you used, and why did you decide to use that methodology?
So I guess if we talk about that independent variable first, in terms of their functional performance, we used their hop test score, whether that be the centimetres hopped or the repetitions performed. We kind of put that variable into 2 different forms, I guess. So one was a continuous variable, so we kept the centimetres as centimetres, or the reps as reps. And then the other way that's commonly done in the literature is looking at the limb symmetry index, so percentage of function of the ACL limb of their non-injured or contralateral limb. Usually we use that cut-off of 90% to define whether someone has poor function. So less than 90% poor function, because we think that there's around a 10% asymmetry in normal subjects, and that cutoff has also been shown to predict future re-injury and symptoms and patient-reported outcomes as well. So I guess why we spent a lot of time on this in terms of deciding how we're going to put those variables in the statistical model, and we chose to do both because there are, I guess, some limitations to what we call like dichotomizing your variable. So that 90% cutoff. So you might have someone who's got 89% LSI and someone who's got 91% LSI, and in clinical practice, those two people might not actually be too different. They're only 2% apart, but they actually fall into completely separate groups in the model. So you can begin to understand, I guess, the flaws with that. And some of the work of Dave Carey in looking at like the acute chronic workload ratio have looked at how you can just get completely different results and outcomes from doing your stats like that. So we thought it was really important to then put the actual continuous measure in as well. What else do you want to know about the stats?
What else do I want to know about the stats?
I guess
whatever you want to tell me. Just for the listeners, so generalized linear models with Poisson regression and general estimated equations. What does that mean in English as a sort of introduction to how you're going to attack your stats?
I guess the linear model part of it is that we are assuming that there is a linear-ish relationship with as someone's function becomes worse, their, say, Coues score becomes worse. So if you just think of a graph, the generalized estimating equations, because when they grade the MRIs, there's lots of different lesions in different areas. So trochlear, patella surface, and obviously if you've got one lesion in one area, you're probably more likely to have another lesion in another sub-region. So what that does in the model essentially is to account for that correlation. Yeah, and then obviously you just use different models whether your outcome is continuous. So the reason why it's different for the Coues is because that Coues outcome is a continuous score out of 100, whereas the worsening OA features is a yes or no outcome. They either have it or they don't. So
yeah, what was the most difficult part of completing the research from a methods perspective? And in hindsight, is there anything that you would change in the way that you put this study together?
Good question. I think the most challenging thing with a lot of our work in the ACL field is that there's so many other factors that might influence our outcomes. So whether it be the structural outcomes or the patient-reported outcomes. So even though we've got a nice cohort of 80-odd participants, the statistical rules are kind of, you can't kind of account for other things in your model. So say if you've got 80 participants, you shouldn't really have more than kind of 8 covariates, which are the other things like age, sex, body mass index that could also influence the outcome, and those things also go into the model. So you need to, I guess, decide what you think is most applicable for the outcomes that you're looking at.
And then you're trying to homogenize as much as possible kind of those other variables.
Yeah. So that was pretty challenging. And also just that, as I mentioned before, there's a wide range of where people are at, particularly at 1 year. So I guess if you think that someone might have already kind of reached their peak at 1 year, fully recovered, so therefore their change in their outcome after that might not be very much, whereas some people kind of might still be recovering and then they actually get a lot of improvement in that 1 to 5 years. Or you might have kind of people up here and they actually like get worse.
Yep.
So I think and then on to your next question, what I would potentially change is, because they're still kind of improving and the other literature will support this up to often 2-3 years, and then they plateau out after that on average. If we had our baseline, say at 2 years, we might have like a more homogeneous group, if that makes sense.
Yeah. All right. Well, we'll get into the results then. So First of all, and then this is such a rich paper in terms of both sort of description as well as all of the statistics that are included. So if there's a better section in the paper that you will kind of want to move towards or jump into, then let me know. Otherwise, we can kind of just sort of go through from page 4 onwards.
There's probably like in that just first results part, there's some pretty key information in that kind of second sentence. So you can see that 10 participants, or 12%, had poor functional performance on all 4 tests. So they had less than 90% LSI on all those 4 tests I mentioned before. And then in comparison, only 18% would have passed the test battery, so scored greater than 90% on all 4 tests. I guess, again, the reason why we chose to define poor function as kind of failing all of those 4 tests, when in clinical practice, if you failed one, you would fail. We just really, I guess, wanted to highlight those with kind of, I guess, extreme poor function, to look at that relationship with structure and symptoms. And people probably don't go to the SAP file, but there are some extra information in there in terms of how many failed at least one test, at least 2 tests, or like any test. So, but just a take home is that around 1/3 were failing any one test. So I guess that's pretty important clinical information in terms of how people are doing at 1 year, especially when a lot of them were going back to sport and had returned to sport at this time.
I suppose it depends on the lens that we're looking through this. So if you've got a poor functional outcome, we're describing, you might be in a general population who just wants to be able to do their ADLs without pain, then we'd say 4 was, but as you've described. But if you've got an athletic population, then they're going to fail if they've done, or you'd say a poor outcome might be they failed one of those 4 tests, and you're going to hold back that return to play option. So a little bit dependent on those groups.
And then I guess, so that was, I guess, the descriptive part of it, but was quite interesting in terms of the relationship between those who had poor function at 1 year and those who had worsening over the next 4 years in those cartilage, bone marrow and meniscal lesions. We saw that those that had poor function on all those 4 tests, they had a 4 times increased risk of worsening patellofemoral bone marrow lesions. And then if you scroll down, so these are obviously a lot of numbers, but the 4 times actually comes from that 3.66 number, so rounded up there, and then those other bolded numbers in that PF bone marrow lesion column. I don't know why I'm pointing.
Yeah, I was going to say the pointing over there. I can't quite see that one, so you might need to be a little bit more descriptive for me.
If you go to the second column, there. So if you scroll down that column, the bolded 4.17, all those bolded numbers down there in that column, those ones coming through there. That is a risk ratio, but so in other terms, that means, and if you want to read this later, is that a risk ratio, the significant results are in that kind of using that 90% LSI cutoff, and there was only one significant result with using like the raw score. So I think that's, it's an important point to note because most other studies will use that cutoff. But if we're just looking at the raw relationship between someone's function increasing and their risk, there isn't as much to see there. So you do interpret, if you go to the 1.08 in that bone marrow lesion column.
So yes, here.
Yes, So you interpret that a little bit differently. So that is in relation to the side hop test. So that is basically saying for every 1 repetition increase in the side hop test, for every 1 repetition decrease, their risk of worsening patellofemoral bone marrow lesion goes up by 8%. Say it's just so that it's the raw score. So they might score 20 some people might score 10 reps, some people might score 30 reps on that side hop test.
Yep.
So for every one repetition decrease on that test,
Yep.
Your risk goes up by 8%. So that's the 0.08.
Right. Okay. But is it decreased from a specific level or just a decrease from?
No, just yeah, it's kept as a continuous measure.
Okay.
Yeah. Yeah.
Anything else from this table? I think that sort of summarizes. That's a useful table to see. So would you suggest that clinically then that where we've got the statistical significance would be the functional test that you would favor clinically then to be able to draw these inferences to potential OA risk and features? Or do you think that a whole battery of tests as it is still of use clinically?
No, I definitely think using the whole battery. I mean, certain tests are going to, I guess, stress certain muscles and certain loading patterns, but yeah, using the test battery is definitely still recommended. And you can see here that all of the tests were associated. Really, there was only the triple crossover that wasn't kind of statistically significant. So I guess, yeah, clinical take home from this is that one, a lot of people are not passing all the tests. Only 1 in 5 would pass this battery. So one, I think it's a challenging battery, but that is a good thing, especially if they are wanting to go back to kind of cutting and pivoting sports. And maybe these patients need some ongoing rehab, even if they aren't returning to sport. I think is the key thing to also mention here is that this study then shows that they're at an increased risk of some of these features worsening. Yeah, just because they're not going back to sport, having good function is important for their future joint health. So even though they might not be at risk of re-injuring because they're not going back to sport, it's still important.
All right, so that covered is there anything else in terms of the actual the patient-reported outcome scores then that we want to touch on here?
Yeah, so I guess similar, setup in terms of that table. If you scroll down, so that was the function to the change in imaging. If you go to the next table, there's not really any bolded values there, and really we didn't see any relationships between people's function at 1 year and their change in the KOOS or the IKD scores over the next 4 years. So yeah, previous studies have shown kind of strong relationship between if you've got good function, then you've got better patient-reported outcomes to kind of 2-3 years down the track. But yeah, we didn't show anything, and I think perhaps, like I mentioned before, it might have been limited in terms of the time frame we're looking at, in terms of some people were still improving, some people were maybe stable and had reached their peak. So
was that surprising to you, or given those factors, it's kind of made sense?
Yeah, I guess we were thinking that something might pop up, because what Adam did with a similar paper, he looked at the one leg rise at 1 year, and he showed that if you scored less than 22 reps on that test at 1 year, then that increased. You had worse KOOS scores at 3 years. So he did a little 3-year follow-up. So we thought maybe that that might a similar trend might pop up, but it didn't. Again, I think maybe there's lots of things that are impacting these young adults in this time of their life. So especially things like quality of life and sport. You've got lifestyle changes and priorities that might affect those things, and what you've kind of changed in terms of your physical activity as well. So I think there's a lot of things going on, and that's the challenge of, I guess, predicting these patient-reported outcomes in this population.
Okay. Let's just go back to We all like a good image with a bit of colour in a paper.
Yeah.
Why did you choose to include this in the early part of your discussion? And can you just talk the listeners through? So at bottom of page 5, just a diagram to show some of those functional performance cut-off points and back there.
Like I said, my supervisor likes the patellofemoral joint, so lots of little patellas.
Yes, yep, lots
in a
of
paper. No, so I guess something visual. So each of those little patellofemoral joints represent a participant in the study.
Yep.
So the grey ones are people that they didn't have any worsening patellofemoral bone marrow lesions. And they actually might have been improving. So we did see, if you refer back to the other paper, that we know that bone marrow lesions might be traumatic and they actually do improve up to 2 years. So the grey ones are either stable or improving, and the orange ones are our worsening people. So, and then the blue line up there you can see on the x-axis is that 90% LSI cutoff. So this basically represents everyone in the cohort and their where they fell on that LSI scale. So you can see down the far left there was 4 people that actually had a 5% LSI, so they might have been able to do like 100 centimetres on their non-operated limb, and then they might have been able to get like a tiny little hop on their ACL reconstructed limb. So they've got a really low LSI. And then you can see most of them are up around that kind of between 65 and 100 mark. So it was to try and, I guess, show that the majority of those orange ones are falling below that 90% cutoff. And then there are a few that had good function but still had worsening lesions.
All right, let's pop down towards, I think that's covered most. Is there anything else on the results you wanted to touch on? Otherwise, we can just we'll probably come to some of the summary points.
No, I think we've covered it.
That's it. Okay. So from a sort of clinical perspective, and you mentioned a couple of things, but firstly, what do you want clinical practitioners to be able to take away from this paper?
Yeah. So the first thing would be that the majority don't pass this test battery. So I'd encourage clinicians to, they don't have to use these exact tests, but use a test battery that challenges the patients in multiple different aspects. So as I mentioned before, the kind of multiple planes of direction, aspects of strength, aspects of repeated power generation, endurance, fatigue, because we also know from other work that more people are likely to fail if you use a range of tests as opposed to 1 or 2 tests. So that would be the first take-home message. And then on the back of that, I guess it's trying to keep patients engaged with rehab. If you do feel that they've still got some of these end stage goals to achieve, I know it's challenging to kind of keep them coming back, but I would really, I guess, value your assessment and education as a treatment. So you don't need to be prescribing whole new exercise programs or coming up with new things to kind of get those patients to keep coming back to see you. So try and, I guess, motivate them to, continue to engage in their rehab. So I know it's challenging, but that's, I think the biggest thing in this patient group is that end stage rehab and getting that kind of multi-directional power happening.
Great. And what sort of stage, I know it's difficult, I'm sure there's probably some precursors to it, but when do you advise clinicians start to use a battery of tests like this in that journey?
Yeah, so I think, the reason why we like the one-leg rise as well is it's something that you can use pretty early on. So even if they can't squat on one leg to 90 degrees, you can modify it and, you can do it to 70 now. And then they might be able to then achieve that 90 degrees, and then they might only be able to do a few. So it's a good one to kind of use throughout the whole rehab as soon as they can starting some of that single leg strength work. And then in terms of the hopping, then obviously they need to have done a lot of single leg strength work and a little bit of intro to impact type activities before you throw them into a hop test on the reconstructed limb. But I would be doing these tests on the other limb as early as possible. So there's a lot of work to suggest if you can do it actually pre-operatively.
Yep.
Before they get that deterioration in the contralateral limb, that's ideal, or do it early post-operatively. So you really have a good benchmark or standard for that LSI measure as well. So I didn't mention it before, but there's obviously limitations to using the LSI because the contralateral limb we know that it deteriorates as well. So by 1 year, it might not actually be kind of that person's best performance. So that's another little side.
I think we're seeing that in a range of different regions of the body now, aren't we?
Yeah. And then I guess, the other take home is from the poor function group and that association with the patellofemoral bone marrow lesion and cartilage worsening. I guess it's motivation to get that function up to scratch, not just if they're going back to sport or not just to reduce re-injury, that it is associated with an increased early structural changes. And as I mentioned at the start, the clinicians might be saying, okay, so what? They've got MRI. This increases their risk of MRI lesions. MRI lesions are not associated with symptoms, and maybe in some people, radiographic changes are not associated with symptoms either, but it does place them at an increased risk, we think, of progressing to that more established joint disease. So if they're showing these accelerated changes only kind of 1 to 5 years after surgery, it means they probably are going to be in a worse place kind of 10, 15 years down the track, and it might increase their risk. So they may not be benign, I guess, is a way to kind of think of it. Yeah.
Okay. And I'm going to put you on the spot here, Brooke, and just say, if you've got a patient 6 months in post ACLR, what are the 3 most important one sentences you think that patient needs to hear? Whether that's encouragement, or what are the key things that they need to hear to help them get a successful outcome?
I think the biggest mistake I made was, once you can run, once you can, your physio's tested you, you can hop and squat. It's like, sweet, I'm just going to play sport now and not worry about these exercises. Doesn't happen to everyone, but consequently my meniscal repair kind of didn't go so well down the track, and I didn't keep up that strength work. And now having been part of an elite sports program and being really strong and knowing how much better my knees and whole body feels from continuing that, as well as your sport-specific activities, number one tip.
So a big difference between return to activity and actually return to play or return to match play. Yeah,
and I guess because we're talking about hop tests as well, it's difficult for patients, I think, to do these types of rehab activities. So it's a lot easier, I think, for people to go to the gym and do their weights. But some people feel funny about hopping around in the gym or even outside. They feel like, oh, no one else is doing this. People are looking at me. So I think we really need to guide patients through that. And that's what I was touching on before. They might not be coming back for new exercises. They might be just coming back to actually be supervised, and they do their plyometric and agility stuff with you, and that's their physio session.
All right. Anything else you want to add before we wrap up, Brooke? Otherwise we might leave it there.
No, I think I think we need to kind of continue to explore that return to sport battery. Obviously there's other things like strength testing. LSI might not be the best measure. We need to kind of understand what is good function. So if we're not using the LSI, is 100 centimetres hop for that person good, or do we need to be pushing them for more? So I think we need more information in that area to kind of guide our return to sport battery.
Okay. And what's next for you? I know that you are busily writing away to finish that PhD sort of towards the end of the year, but what's next in terms of research for you?
So got my finger in lots of different hires at the moment, and there's lots of exciting projects going on at La Trobe. So my supervisor Adam and Kay are about to start a big trial. Hopefully once the world gets back to normal, we'll be recruiting some ACL reconstructed people who are kind of, I guess, in this at-risk group. So they've kind of haven't achieved the outcome that they want to achieve 9-12 months down the track, and then we're doing the RCT in terms of giving them some progressive strength training. So that's going on, involved in that a little bit. Also some primary prevention stuff in female football. We've got a few projects going, and as I mentioned, this cohort are coming up to 10 years, so I'll be helping, the team will be kind of getting them to come back in for x-rays, I think, and probably a couple of the patient-reported outcome measures. So it'll be cool to look at some of that stuff as well.
All right, excellent. And I'm sure you're going to be as busy as any clinician as soon as we return to full activity. It'll be interesting to see how many additional ACLs we get post lockdown, or whether we can kind of keep that on the track with some successful kind of return to activity programs. So.
Yeah.
All right. So where can people find you? Just quickly, where if they want to follow your work and the activity you're doing, you're on pretty reasonably busy on Twitter.
Yeah, reasonably busy. Go through phases, I think. It's a bit of a tricky one, my Twitter handle. It's knee_how, so knee as in the knee we've been talking about, and my maiden name, so it's a little bit of play on words.
Okay, I like it.
House, yeah. If you just type Brooke Patterson, might be.
I'm sure people will find you. That does seem very.
But yeah, in saying that, like, love to hear from people if they've got ideas, research questions, or just generally interested. I've got questions, then message me on Twitter or email me. Yeah.
Okay. All right, Brooke. Thanks again. It's been a pleasure.
No worries. Thank you.